Oui, je vous entends. Oui, je vous entends très bien.
AMREF Health Africa is Africa's largest indigenous health development organization, operating in up to 35 countries, depending on our project footprint at any one time. Having been in Africa for the last 63 years, we know that actually community context matters, policy context matters, strategy and priorities, country priorities matter, and therefore we do not take that one size fits all, and therefore we believe in a unique Africa health agenda. It is with this in mind and with our vision of lasting health change in Africa that we decided to be convening every 2 years a big convening, which is the Africa Health Agenda International Conference, or in short, Africa Health Conference, which happens to bring together governments, bring together the young people, bring together policymakers, practitioners, communities as well, advocates, partners from Africa and from across the world to discuss the Africa Health Agenda on African soil. We have held several of these conferences, and the most notable is the one of 2019, where we brought over 1,800 delegates from 49 countries into Kigali, Rwanda in March 2019 to discuss how Africa was prepared and preparing to achieve universal health coverage by 2030 to ensure everyone has access to quality health services without financial difficulty in an accountable manner. We had over 7 ministers of health attend from Africa. We had over 500 young people come together for a youth conference, and out of that was born the Youth for UHC movement. We brought conversations of private sector engagement. We brought conversations on civil society engagement for UHC movement. At that point, the world was preparing for the UHC.
Great. Good morning, good afternoon, and good evening, everybody. Welcome to the AHEC 2021 Plenary 1 session on Leadership for Change, Africa's Journey to UHC. We are delighted that you've chosen to spend your valuable time with us, and we do look forward to learning and sharing together. Happy International Women's Day. May we recognize, may we celebrate, and may we elevate women today and every single day. The COVID-19 pandemic has exposed gaps in our already fragile health systems, both in Africa and worldwide. What started as a health crisis quickly snowballed into an economic crisis and then a social crisis. And what we learned is that a holistic approach to health and its social determinants needs to be re-emphasized. UHC, or Universal Health Coverage, applies this systems lens and approach in ensuring that health and well-being is available, is accessible, and is affordable. There's a critical role for both country-led and regional leadership in Africa and around the world to call and shape global flow of resources and different types of resources so that we can move from doing business as usual in the health approach. Our distinguished panel today will begin the conversation during this session, which we hope to continue in the chat box, and I see we are already typing into the chat box, as well as on social media and all the other advocacy platforms that we have. You've just watched the video that started the session, and so we'll just quickly go into the panel discussion. I would like to briefly introduce my panelists. More details on their amazing careers and contributions to impact are available on their LinkedIn pages, so go and type in there, but I will just briefly introduce our panelists today. We do have 6 amazing individuals who are joining us today. I'll start with Honorable Leah Tedese. Honorable Leah Tedese is the Minister of Health for the Federal Democratic Republic of Ethiopia. She's an obstetrician and gynecologist and has had extensive career in the civil service, as well as in other areas of health, including academia and program management. Welcome, Madam Minister. I would like to also introduce Dr. Roger Kamba. Dr. Roger Kamba is a special advisor to the President for UHC in the Democratic Republic of Congo, has had an extensive career and held various roles as well, and over 20 years of experience in taking care of our little ones through pediatrics. Welcome, Dr. Roger Kamba. We are still expecting Professor Omaswa, but we will continue with the rest of the panel. We do have Dr. Lade Hamed. Dr. Lade Hamed is the General Manager of Roche in Nigeria. He's a healthcare physician who has worked extensively both in the public and the private sector and has held several roles in Roche before leading the team in Nigeria. Welcome, Dr. Lade. And then we have Helga Fogstad. Helga is the Executive Director for the Partnership for Maternal, Newborn, and Child Health. She's a health economist with more than 30 years of public health experience and has held multiple roles, even in international development organizations such as NORAD. Thank you so much, Helga, for joining us in this conversation today. Minister Tadesse, as one of the few countries that achieved the MDGs before the deadline, Ethiopia continues to be a beacon of hope and example with UHC. You have extended health services beyond the facility level up to the household level using your very robust primary healthcare system. Madam Minister, what did you do to get it right in Ethiopia from the very beginning? And how has leadership been very critical in this achievement, not just in the past, but in the plans going forward for UHC in Ethiopia? Over to you, Honorable Tedese.
Thank you very much, Dr. Angela, and wonderful to join this great panel on this very important topic, especially while we're fighting this pandemic. And as you rightly said, primary healthcare in UHC has been a top agenda for many years in Ethiopia. And it starts, I believe, with our health policy that we have been implementing for the last more than 25 years, which primarily focuses on approach of disease prevention and health promotion and primary healthcare system, strengthening primary healthcare systems, which led to the establishment of our flagship program, the Health Extension Program, which has now been here for the last more than 16, 17 years. And this was mainly as a big country with a large rural population and the burden of illnesses being mostly communicable diseases and maternal and child illnesses. The leadership at the government level and also the health sector has always prioritized to ensure access to the community level. And that was what led to the birth of the Health Extension Program, with currently more than 40,000 health extension workers who do three pillars. They do disease prevention, health promotion, and basic essential healthcare services at the community level, both in households and in the health clinics, which we call health posts. So that really had a significant impact on reducing maternal and child mortality and morbidity and mortality from communicable diseases from early on. And we have continued to build on that and at the different health care systems, ensuring that the essential healthcare packages are also in place. But of course, we have a lot of demographic and different socioeconomic changes progressively, which require to still focusing on the PHC as a pathway to universal health coverage, but also ensuring the integration of non-communicable diseases, injuries, and others is what we are currently also working on, building on what the foundations that we've had already.
Thank you very much, Honorable Minister, for that. And you're quite right, especially in Ethiopia, which is such a large country and such a significant population of over 100 million, having those 40,000 health extension workers reaching the household and 4 million health development army ladies in the community really role modeling what it means to be healthy is quite critical. Over to you, Dr. Kamba. The Democratic Republic of Congo is also a significantly large country as well. And you recently experienced the Ebola outbreak and the great work that was done to deliver more than 400,000 doses of the vaccine. The world and Africa right now is facing the COVID-19 pandemic. Where do you think the largest and greatest opportunity lies, not just in DRC, but the rest of Africa, in building healthcare systems that are more resilient and responsive to the health needs of our time? Over to you, Dr. Kamba.
Merci beaucoup, Dr. Angela. C'est un plaisir pour moi de participer à ces échanges. Et je suis content de voir la ministre Tadesse d'Éthiopie, parce que j'étais en Éthiopie hier et je suis revenu d'Addis Abeba hier. Avant la Covid, un des pays qu'on devait visiter pour apprendre sur la couverture de santé universelle, c'était l'Éthiopie. Mais avec la Covid, on n'a pas pu y aller. Mais pour nous, je pense que la première leçon que nous avons apprise, c'est que la santé ne doit pas être considérée comme une dépense financière, mais comme un investissement. Je pense que ça change beaucoup au niveau de la compréhension du gouvernement, parce que nos dépenses de santé étaient très, très faibles, parce que ce n'était pas considéré comme un investissement. À partir du moment où maintenant, dans notre plan, nous comprenons que c'est un investissement, alors les efforts deviennent beaucoup plus cohérents. La première cohérence, c'est vraiment la globalité. Je reviendrai sur Ebola et nos épidémies après, mais la première cohérence, c'est la globalité, la multisectorialité, parce qu'on ne peut pas, dans notre contexte, parler de la couverture de santé universelle seulement avec le secteur de la santé. Je vous donne un exemple. Dans notre pays, aujourd'hui, le sida tue plus que, les accidents de route tuent plus que le sida. Alors, or, c'est un département de transport, du ministère des Transports, qui gère ce problème-là. Et si nous ne nous attaquons pas donc aux déterminants de la santé qui sont éparpillés, même si nous investissons sérieusement dans le système de santé, nous n'arriverons pas à la couverture de santé universelle. C'est un dossier, l'exemple qu'on peut avoir avec la malnutrition, qui chez nous ne relève pas du ministère de la Santé, mais d'autres ministères. Et pourtant, elle constitue une base importante du poids dans le système de santé. Donc, la première leçon vraiment que nous pouvons tirer, nous, elle est double, c'est que d'un côté, c'est un investissement. On ne doit pas considérer ça comme une dépense, mais quelque chose qui va ramener au pays une plus-value économique. Et d'autre part, considérer que ce n'est pas seulement le ministère de la Santé qui doit être impliqué, mais de façon générale, plusieurs ministères qui contiennent les déterminants de la santé. Je pense que c'est sur cette base-là que nous avons commencé à travailler sur notre couverture santé universelle. Bien sûr, en regardant les piliers les premiers axes que nous allons regarder vraiment, c'est la santé, ce sont les soins de santé primaire. Et ça, c'est en échangeant avec le directeur Tedros il y a un peu plus d'1 an que nous avons levé aussi cette option-là, parce que je sais que l'Éthiopie est passée un peu par ce schéma-là. Voilà à peu près la base sur laquelle nous avons commencé à travailler. Merci beaucoup.
Merci beaucoup, Dr. Kamba. Félicitations as well on the great distribution of the vaccines, D'accord. Professor Maswa, welcome, Professor Maswa. Professor Maswa is Executive Director of the Africa Center for Global Health and Social transformation. He's also a AHIC commissioner. He has had an extensive and illustrious experience within the health industry, most notably as a former Director General of Health Services in the Ministry of Uganda, as well as other roles, including an advisory role with the WHO. Welcome, Professor Maswell. In the recently concluded AU Summit, the interlinkages between health and development were very evident, especially looking at the impact of the pandemic. How do we ensure that leaders continue to prioritize investments in healthcare and not just the GDP growth, as well as how do we help them make the right decisions in this post-pandemic phase that we're experiencing?
Thank you, Angela, and good afternoon, fellow panelists. It's such a pleasure to link up with the Honorable Leah Tadesse again, and Helga Fogstad from the partnership. These are two people with whom I have already had some experience of working together, and nice to meet the other panelists. So back to the question Angela has asked. I really see this whole conversation now as an opportunity for Africa to make another beginning from the great beginning that we had at independence time, which got upset by a variety of things. But now universal health coverage, SDGs present us with an opportunity, together with the rest of the world, to close that gap which exists between Africa and the rest of the world. And one of the points you have mentioned, Angela, is critical to this journey. Namely, that after Africa lost its promise, maybe some like 10 years or less after independence, we became very poor for a variety of reasons. Mismanagement with military dictatorships, the Cold War between the Soviet Union and the Western countries, collapse of commodity prices, price of oil, and so on. And then we went to beg for money. And they gave us money and ideas. I know growing up in the health system in Uganda, even being a leader here, partners who were giving us money planted technical advisors, they called them, into our ministries of health. And by and large, they are the ones who called the shots. We need to regain our self-belief. We need to regain our ambition, a new mindset which feels pain and shame at Africa lagging behind the rest of the world in terms of development indices. So armed with that, we take advantage of the rest of the things. For example, those experts who came to our ministries of health and ministries of finance, they were generally economists. And they told us that health was a consumptive sector. They divided the sectors into productive and consumptive. And as Director General in the Ministry of Health in Uganda, every year, we would go to the Ministry of Health after they have already invited the so-called productive sectors. And then the rest of us, health, education, social development went later. And health was not seen as an investment. But we've moved away from that now. There is strong evidence that investing in health is the best investment. The purpose of all SDGs is about health and well-being of people and the planet. So we've moved away from that. The health economy itself, Germany, for example, like 30% of the German economy is related to health, manufacturing drugs, machines, and all those things, and employing people. So that answers your question. So we need to come back with a new brand, a new paradigm in leadership. Namely, the earlier speakers at the opening ceremony spoke very well. We need to get mutual accountability between the people, the government, and those who generate knowledge. Dr. Tedros says the link between science and politics is important. That is it. That's where it is. I will end just by saying that in the future, moving forward, the Thais taught me about the triangle which moves mountains, namely that one corner of the triangle is the people, the population. What are their needs? The other corner of the triangle is knowledge generators, academia and research centers and CSOs and so on, answering the question, what do the people need? How do they get it? And the third corner of the triangle is politics, politicians, who between these two other sides of the triangle, the politicians should just be implementing what the knowledge generators have done to answer the needs of the people. So we need this partnership moving forward, strengthen our research, strengthen our demand side from the people, and then politicians, if they want to get our vote, they just have to do that. Let me stop there for now.
Thank you very much, Professor Maswa. I'm taking it positively that we health economists in the ministry also could add value in the conversations within the ministry as well. But you are right. For a long time, health was seen as this black hole, this cost center that actually did not generate any returns. And we have continued to prove over and over again that there is a return on investment in health. Our team recently, actually in 2015, just proved the 10-to-1 return on investment in community health. And there is an economic return, there's a social return, there's a health return on investment, and all this is actually quite evident. You also said something very interesting, Professor Maswa, that there are various stakeholders in this conversation. There are these three sides of the triangle, as you put it, and one side of that triangle is about generating the information, the evidence, and bringing many stakeholders to the table. Part of these are the private sector. And Dr. Lade, the private sector has a strong role to play in advancing UHC, strong R&D capability, strong innovation, strong technology are really great enablers for universal health coverage. Using examples from Roche, what scalable and sustainable initiatives are being implemented?
Thank you very much, Angela, for the question. It was really interesting listening to Prof. Omaswa's comments. I mean, UHC is extremely important to us at Roche, and we believe it's the only equitable way that we can deliver healthcare to people generally. One of the few measures we have taken at Roche and across countries in Sub-Sahara was really changing our business model. And we did that to look at a different way to distribute medication and drugs to hospitals and governments and health insurance agencies. The complex distribution network, we streamlined our distribution network such that we were able to deliver drugs directly to the hospitals and accounts, thereby removing about 30 to 50% of the cost of the medication and giving that directly to the hospitals and to the patients at a much lower cost. That, as an action that we took, really made drugs more readily affordable and available because we could guarantee the quality of the medications, the supply chain, the product quality getting to the accounts. Something else we did, and Dr. Campbell would be aware, is going into partnerships with state governments. And we had a really great example with the RDC, where we worked with health sector stakeholders to go into the field and see the challenges that were present in the ecosystem in RDC. And together with them, over a week, and about 60 stakeholders in RDC come with sustainable solutions on how to implement good quality cancer care in RDC. Now, after that week-long deliberation, we came up with an MOU on how to build diagnostic laboratories in RDC. And not only do we have the MOU today, we have actually started implementing such an idea where we have labs today that are able to do diagnosis for cancer care in RDC. And patients are beginning to benefit from this totally free of charge to them. And that is what partnerships like this can do for UHC, where companies like ours can work together with the public sector to ensure that delivery of UHC is optimal and is properly implemented?
Thank you so much, Dr. Lade. You've actually touched on a couple of things, and I think also the Honorable Minister talked about it. The burden of disease on the continent is changing. For a long time, there was this focus on communicable diseases, but the kind of burden of disease we're facing right now is not just the communicable disease. We have an increasing and growing non-communicable disease burden as well that we do need to focus on. But still, largely, majority of the burden of the disease still is preventable in one way or another. And Helga, maternal, neonatal, and child health is critical. The pandemic has disrupted essential services and disproportionately affected women, adolescents, and children. Your latest advocacy brief, Finding Hope, speaks of the lived experiences of women, adolescents, and children during the COVID-19 pandemic. How do these stories of African women and children stand out from the rest of the world?
Well, thank you for that. And thank you to you, Angela, and thank you to my honorable panelists. I'm so honored to be a part of this. I think what we have heard and seen also from the data, that inequalities before were bad and now with the pandemic has only increased. And so we're actually more in trouble now than ever before, not only on the direct causes, but also the indirect causes who have really slid us back substantially. And this is really serious. And I think we, knowing the high investment, investment case for addressing women, children, adolescent health services and well-being, we can not avoid to pay heed to that. So what do we need to do? We need to also listen to the voices of women and girls. What are they telling us? And one thing that I would like to share is, the impressive campaign of White Ribbon Alliance with What Women Want, and also the hope documentation of, lived experiences and what women and children and adolescents need. And it's going to be security, it's going to be safety, both outside and inside the doors of their own home. So I think this is something that we collectively have a responsibility to understand and to take action on, because we cannot leave it to chance. We cannot leave it to something that our leaders are going to understand as either, something like primary healthcare or universal healthcare. Because if we do not, Angela, make this explicit, it will be invisible and it will remain, and women and girls will be paying with their lives. And this is something that we cannot stand and really see to. We have a moral obligation to really act, as several of my panelists have said, in partnership and in effective partnership and moving forward. And this is what PMNCH has done. The Partnership for Maternal and Newborn Child Health has come up with a campaign, has come out with evidence-based really 7 clear asks of what is needed for governments and other partners, including private sector, to really pay heed and move not back better, move forward better, and have the future be somewhere where we are all in paying attention to financing for equity and financing so that it comes to really social development in a better way. So I'd like to really emphasize that, Angela. Thank you.
Thank you so much, Helga. And that's true. I mean, the voices need to come out, and it is true. Women have been disproportionately affected by the pandemic. They're the ones in the high-touch industries who potentially lost their jobs. They're the ones who had, in terms of the services that needed to go to the household. Most of the marginalized communities are women and young children. Community-based services were not being delivered necessarily to the extent that they needed to be. So you are right. There is a disproportionate impact on women. And actually, on that, just to add the voices on this particular panel, and for all those people who are in our chat box, all 380 of you, please continue putting your comments and putting your questions. But we'd really like to hear from the field and from the community, and we do have a video on voices from the community on UHC. And so if the technical team could actually play that now before we go into our next session of questions.
My name is Ruben Pajes. I'm from Cuba. UHC means that everyone can access the health that they need without discrimination.
My name is Berito Mredi. I'm governor of Laikipia County. It's about quality of life of the citizen. All the things that government do, it's about the quality of life of the citizen. So, and you can't have a quality life without health. So health is a foundational issue for improving lives of citizens.
My name is Masiongo from Nairobi, Kenya. UHC for me means everyone can access quality, affordable healthcare.
Hello, my name is Owen Brady. I live in South Africa. For me, UHC is allowing governments to take the opportunity to use evidence to make trade-offs and maximize health for everyone.
My name is Hajra Mukasa from Uganda. Universal health coverage to me is everyone being able to access the basic needs of health, irrespective of your race, your tribe, and your socioeconomic class in society.
My name is Ukende Shala. I'm from Tanzania. UHC to me is a quality care to everybody, regardless of age, sex, and community member.
My name is Otinia Nimbaz. I'm from Rwanda. Universal health coverage for me means better and quality health care.
Name is Frank Ategeka. I come from Uganda. UHC means each person, irrespective of where they are, should be able to access health care without financial hardship.
My name is Dr. Thuranira Kaugeria from Kenya. UHC means quality health care for everyone. It is not poor medicine for poor people, but quality health care for everyone. What my grandmother down in Meru will enjoy should be the same service that Dr. Thuranira should enjoy in Nairobi.
My name is Esther Ndokolo Kikitobo. I'm Congolese and I'm a international student. UHC to me means people having access to healthcare services, including health promotion, prevention, treatment, rehabilitative care, and palliative care without suffering financial hardship.
My name is Magnus Conte, and I'm from Sierra Leone. Universal health coverage to me means healthcare provision for all.
My name is Imalia Sana from Nairobi, and universal healthcare means to me equitable access for everybody.
My name is Kendi Mburu. I'm from Kenya. UHC is a right, and it's about comprehensive, accessible, quality healthcare for all citizens of a nation, regardless of the nation in question, and also regardless of the sex or the economic or political background of that individual.
My name is Justin Dikugayo from Burundi. For me, UHC means you and me having access to quality health facility despite your social and origin background.
My name is Siego Jacqueline and I'm coming from Cameroon. UHC means for me the possibility that someone, whether you are a man, a woman, a girl, a child, to benefit from services of health, whether you have money or not.
My name is Masama Esonarwa. I come from Togo, West Africa. Universal health coverage for me is advocacy in providing quality and affordable health care.
My name is Matilda and I'm from Sweden. UHC to me means access to quality healthcare for everyone, and that is accessible and affordable by everyone, but especially young people, as they are the future generation, and that will provide access to health for their communities through digital means.
I'm Mariam Tahir. I'm a medical doctor. I'm from Somaliland. What UHC means to me is rights. Right to access, right to quality of healthcare, and right to sexual and reproductive health.
My name is Mohamed Shani Abdullahi and I come from Ghana. UHC means a world where everybody, no matter where they are coming from, enjoy their right to access to healthcare services and information.
I'm Moses Ngwila from Malawi.
To me, UHC means people from all walks of life and the community are accessing services, be it promotive, curative, rehabilitative, or palliative, in a quality way and that are cost-effective.
My name is Chiara and I'm coming from Switzerland. UHC means to me that no matter who you are or where you live, you have access to quality healthcare services and you have no financial hardship as a result.
Fantastic. So please don't say that this was a panel of 6 people. As you can see, we've had very many voices from all over the world, including your voices in the chat box. So continue putting your comments in the chat box and responding to some of the questions as we continue to have this conversation. Thank you so much. I'm seeing a lot of comments in the chat box, comments around making sure that we do have incredible services available to people. Thank you to Shome. The beneficiaries is communities, the knowledge generators and the politicians should come together. Yes, it's a partnership. It's really a partnership, an approach to, as everyone is saying. Dr. George, thank you so much. Incredible insights. Decolonizing public health must start with ourselves and our mindsets. Very, very true. It is with us, and it's all about us and different members coming together and standing up for what we believe in. And actually, as Helga said, as we were breaking up, we can't keep silent. We must speak, and we must speak up and speak out and speak to the powers that be and make the conversations and make the plans that are influencing us. So it's clear that UHC is an orchestra, many players with unique roles to play so that it actually works. It's a private sector, it's a public sector, it's a social sector, it's the communities, it's the knowledge generators. The communities are not just beneficiaries, but they're active participants. It's the funders. It's a huge orchestra of different players coming together to try and make this work. But that said, collaboration amongst stakeholders is suboptimal. It's not what it should be, to be honest. And Honorable Minister Tedese, countries struggle to align partner priorities with their UHC agenda, but this doesn't seem to be a challenge for Ethiopia. How were you able as a country to engage both private sector and philanthropy in really advancing UHC? How did you get stakeholders to focus on one vision, one plan, one budget, and move in one unified direction?
Thank you very much, Angela. Well, we still have many challenges, but as you rightly said, as a country, I think we do uphold the principle of alignment and harmonization very seriously. And we have been one of the very early signatories of the IHP Plus, so that with that we have actually implemented and started as you said, the one budget, one plan and one report modality. And very soon after that, we had established the funding mechanism, the pooled funding mechanism, which really brought a big impact, which started as the MDG pool fund, which we now use as the SDG pool fund, where many donors put in their money not for a specific program, but for the health sector national plan. In the national plan development process itself, the strategy also, we've been having several 5-year strategies, development plans. In the last 5 years, we have our health sector transformation strategy, which we started the second one currently. And all the process usually involves all our development partners, where they do a joint assessment of the strategic plan independently as well, and then bring it together to get all the input so that the plan is owned by everyone. So it's not just a government plan, it's a national plan that is owned by government, by donors, partners, and all stakeholders within that process. And with the SDG pool fund, of course, not all of our donors are not yet in the SDG pool fund, but we've had a great experience in terms of the funding the priorities of the health sector, the plan, but also efficiency in the use of resources. in terms of reducing different overhead costs, but also efficiency in not having duplications or fragmentations. And also, we do have, of course, our joint consultative forum that's regular with all our development partners, where we do have a transparent process of dialogue, and whenever there are areas of improvement, we continually improve through our joint financing agreements. And we do hope to continue to add many of our donors and partners towards that platform, which has really brought a lot of impact in terms of that process. So it has definitely its own challenge, but it is really the alignment to ensure that alignment, not just in the implementation, but it starts from the planning process and creating that collective ownership and working for the results, focusing on what are the results that come from that collective action. I definitely understand there are some challenges, because definitely some donors want to see the specific results for that specific funding, but the bigger impact, the country level impact, is much higher when we do use the resources in such an efficient way.
Exactly, Honorable Minister, and you're right. Funding currently is not very unified, and I think it's very impressive that Ethiopia has been able to have this performance-based pooled funding mechanism. And the truth is, there's a lot of fragmentation of funding on the continent, and it is inefficient, as you are saying, and it takes many people to come together and pull their funds together, and many stakeholders are able to bring different types of funding to advance the conversation. So it is, of course, nothing is perfect. We recognize that as well, Honorable Minister, but you are moving in the right direction as a country, and it's very, very impressive. And there is a role to actually link the funding to performance. Our team is also trying to pull together a fund, but as you said, some donors are usually very specific about what kind of impact and outcome that they're tracking, but really bringing people together is quite an interesting experience, and thank you so much for sharing that. Dr. Kamba, what are some of the principles that the DRC leadership is keeping in mind when you're redesigning your healthcare system as you're moving towards UHC? So Honorable Minister Tedesse mentioned that they started their journey about 20, 30 years ago, and they've learned a lot of lessons. You're also trying, beginning on that journey as well. What are those principles that you're thinking about as you design the system in DRC?
Merci beaucoup, Angela. Je pense que notre arsenal juridique n'est pas approprié à la couverture santé universelle. C'est un arsenal qui est vieux, qui base le système de santé sur le ministère de la Santé, tout simplement, qui n'intègre pas le secteur privé, par exemple, qui n'intègre pas les apports nouveaux comme la digitalisation, par exemple, et qui n'intègre pas les ressources humaines, par exemple. Les ressources humaines dans notre système dépendent de notre ministère. Ce qui fait que nous avons un décalage entre l'offre de soins que le ministère de la Santé peut donner avec la qualité du personnel de santé. Donc, revoir l'arsenal juridique est une des priorités que nous devons, nous, mettre en place. Au-delà de l'arsenal, c'est de combiner les deux choses. Combiner les soins de santé primaires et la résilience du système de santé à la surveillance des épidémies, parce que vous savez que nous avons eu 12 épidémies d'Ebola, et donc nous savons que c'est un problème qui va être de plus en plus récurrent. Voilà pourquoi nous avons besoin de notre Institut national de santé publique, capable de ne pas attendre une aide ponctuelle à chaque épidémie, mais capable de surveiller, d'anticiper, de prévenir et de prendre en charge les épidémies. Donc, c'est vraiment, d'un côté, améliorer la gouvernance avec un arsenal juridique adapté, mais de l'autre côté, aller bien dans le système de surveillance des épidémies, mais aussi la résilience du système de santé. Nous avons, par exemple, eu une diminution de la fréquentation de notre système de santé. À chaque épidémie, c'est la même chose. Pourquoi? Parce que la résilience n'est pas là et il n'y a pas une coordination entre les besoins urgents et les besoins pérennes. Voilà pourquoi est-ce que nous devons réharmoniser notre système de santé pour qu'il soit viable dans les années qui viennent.
Merci beaucoup. And just for the translation team, I'm seeing some comments around challenges with translation. Please address those challenges. Thank you so much. So, you know, partners are now around the table. Somehow we've gotten them to be unified across one vision and one plan and one budget. But as we plan and really rally stakeholders across a unified agenda, there is a danger of looking at the population as one homogeneous group, right? Helga, how can we appeal to leaders to break free from thinking of engaging populations, especially for women that still live like the most marginalized people? How do we make sure that as we come together to plan and we are thinking about UHC, we recognize that there are different groups in the population that have different needs and they need to be planned for differently in as much as we all have a unified agenda as a country and stakeholders?
Thank you for that really important question, Angela. I think, first of all, data is an important aspect here. We have to know where our women and children and adolescents that are not being reached are in order to better delineate strategies how to reach them. And so there needs to be financing for equity. There needs to be an understanding of where our women and our children are that need most attention. And I think, you know, policymakers and leaders will be very appreciative to understand this better and also to get back and to involve women and activist groups in that. And social accountability is key in this. We need to be involving the public, we need to be involving communities, we need to be involving, empowering women themselves in order to understand not only care-seeking behavior, but also self-care, and to understanding this dialogue between the community and services that need to be part of the solution. So I think, you know, just voicing the Finding Hope, which are partners, AMREF and the Grasa Machel Trust, IPPF, Pro Familia, PAO, UNICEF, and the Center for Catalyzing Change have, you know, they've literally brought 30,000 women's voices to the table. So for us to understand how better we can partner, because women, you know, are partners in this, and you know, usually it's said, you want to you know, save a family, you pay attention to the mother and the wife and the woman, and she'll take care. And so it is very much she needs to be put center into this equation. And I do think that we need to be able to show partners and politicians, and not the least the Minister of Finance. This is where you can help, Angela, in making the case of the investment case, because this is such a high return on investment, not only to health, but social development. And so that's what we need. And no one should be paying with their lives on this, because that's the result. And so I think the recommendations in this report, and I will put the link to the report in the chat box, and I will put it in where the evidence of the 7 asks in our campaign are, that are all evidence-based and need actually all of partners to join hands in a meaningful and progressional way. So that's the message here, Angela. Without partnership, we're not going to be able to do this.
And very true, you know, social accountability and social justice, there's such a key element and pillar on UHC that it is around making sure that we don't leave anyone behind. Professor Maswa, how do we bring this element of social justice, to the transformation among our leaders that is required to ensure that we build systems that serve everyone and not just some of us?
Well, well spoken, all of you, including Helga and the question. Well, that is what I would call the name of our game: social justice. We humans, the way we are created naturally, we are empathetic. Someone is hit by a car, you hear a noise, you look outside your window, and you see someone has been injured, you don't clap and celebrate that. You feel, you say sorry about someone you don't know. So that is what social justice is about. It's about caring for others, not celebrating the suffering of others. It is our humanity, and it's what we need to achieve UHC. So to move forward then, to make it practical, we need to empower the affected. My examples of success, there are two, but let me tell you one. HIV. At the height of HIV, it is the people who were affected who made it uncomfortable for everyone until they got ARVs. But what they did was to influence the political leaders. Remember that triangle. And the data generators. ARVs work. That's what the data generators found. And then at the UN General Assembly, I don't know, Helga, whether you were there in 2001, there was someone there, a big person from a big country saying, oh, Africans can't take ARVs. They tell the time by the sun. And when you say take it at 12 o'clock, they will take it at 4 p.m. and so on. But our own people said that's nonsense. They demonstrated here in Uganda and other African countries that the most loyal ARV takers are here in Africa. So moving forward from here, there are two examples of challenges which I feel where I am now. There's the question of malaria and the question of maternal mortality and neonatal mortality, even infant mortality. Malaria indices have stagnated, even getting worse in other countries, similar to those neonatal and maternal in many countries. So what is leadership to sort this one out? Where does it, how do we switch it on? So I would propose that the way to switch this one on is that issue of engaging communities. Let's create community health systems. Let's have a village health committee in every village. And let's put community health workers as members of that village health committee, so that the mothers there can talk about how to access skilled births, so that those who are, like, again, I was in my village yesterday. There is a relative of mine who's admitted in a hospital. She's pregnant. She needs blood transfusion from malaria now, yesterday. And I think she's still on a drip. How do we get those people who are affected to hold the duty bearers? I mean, there is also this group of us who are only, but our anger, outrage is lacking when we know what is happening and we are there. So I would like to call on African professional associations. There is associations of women doctors, of pediatricians. They are treating dying children and mothers every day. And they are not getting together to to get their parliaments to wake up to this, to go to their communities and say, don't do this until they do this for us. So I would like to push for switching on the affected, creating village health committees in every village, and then getting the professional groups of all types to be saying their thing because they know what should be. So that triangle back again,
Yes.
and then getting the politicians to put the money where it is needed. So that is my solution, and that should be the new paradigm for Africa moving forward. And I hope we can buy that. Thank you.
Thank you so much, Professor Maswa. And it's very critical, and we agree with you. I think we are all aligned. Health starts at the community. Community health workers are critical. We need finance at the table to give the money. We need to design products that meet the costs that need to be there. 70% of community health workers are women, and so it is a gender empowerment program, as we've learned from Ethiopia, from Rwanda, and other countries. But all this costs money, right? UHC may be free at point of care, but it's not free to provide. Dr. Lade, we have like 2 minutes remaining. There are high costs associated with UHC. What's your team doing to overcome the financial barrier to access? In a minute or so that we can have time to wrap up.
All right, thank you very much, Angela. I talked briefly about what we had done with the distribution network earlier, but some of the other things that we're beginning to look at also is the fact that when we talk about affordability, it shouldn't be at the level of the individual, it should be at the level of the community. So in countries where we don't have strong health insurance system, Roche has been a major advocate for how we need to get the health insurance system working. It is only through that communal and community effort that we can actually drive down the prices, along with other innovative ideas. So when we have a strong insurance system that has better coverage, then the prices of services and medications can definitely go significantly lower. Another approach we have used has been what we call the basket approach. So in countries where we don't have strong health insurance system, we have used what we call a basket approach for medications, for services, providing that to countries where they have limited budgets to have an unlimited use of medication and services based on what the country can afford. It's these creative and innovative ideas that we can use to solve health challenges in countries and drive UHC forward. Bringing together the public-private sector together, I think really has to be the way to go. We've seen that COVID, it has worked during COVID, and I think it's what is needed post-COVID to ensure that we get to UHC.
Thank you so much, Dr. Lade. You are right. And I think Helga also mentioned this. We need to, how do we build on domestic resources that then catalyze additional resources? Ministry of Finance has to be at the table and show some commitment. And then folks like you in the private sector come and join hands with the government and make sure that health is actually available and affordable. And this performance-based financing, as we've learned from Ethiopia and Rwanda and other countries, and in what we are designing as a team with the Africa Frontline Fast approach, is just to make sure that we're optimizing on everyone's comparative advantage in terms of the type of money they bring and the kind of information they're bringing to the table. We just have a minute left on this. We are going to go into a video on International Women's Day, and then we will come back before we join the next sessions. But I just want to thank everyone for joining us, and let's continue the conversations on other platforms. There's a video on International Women's Day, and it can be played now before my closing remarks. Thank you.
Merci beaucoup, Angela.
Thank you. If the video, is the video going to play, or I can conclude? As we are waiting for tech team, voila, go ahead. so much, everyone. Thank you to the panelists for your time, for your insights. Thank you for everyone who put their comments in the chat boxes. We are really grateful for making this a very interactive session. As we close, just a reminder, the pandemic has taught us that development issues such as UHC are wicked problems. It's not just about identifying the technically sound solution, but really rallying all the right stakeholders behind the right solution through political prioritization. And leadership is key in political prioritization, and political prioritization is the lever for unlocking the different types of resources. You've heard about skills, financial resources, time, human resources. So let's continue to rally great political and technical leaders to ensure quality of healthcare is prioritized under UHC. Thank you for your attention and for your time today, panelists and all attendees and everyone around the call. Let's pick up the conversation in social media, in our boardrooms and in the community. Feel free to reach out to members of the panel through LinkedIn and their Twitters, and keep the conversation going around the role of leadership in UHC. Please join other parallel sessions that are happening right now. And thank you again for your time. Goodbye and have a very good time during the rest of this conference. Thank you very much.
Thank you, Angela.